It is my great honor to introduce and talk about Dr. Hansbrough for the 14th Annual John Hansbrough Memorial Lecture. Before I get started, I do want to thank his wife, Wendy Hansbrough, for being here today. She comes most years. I think there was one year she happened to be out of town. There was some conflict and she couldn't make it, but she has been here for almost every single one. She joined us at dinner last night along with her son, John Jr., so I thank you so much for coming and supporting this whole lectureship. Now, for the many years that I have been here, Dr. Potenza has always been the one to give this lecture. And he actually knew Dr. Hansbrough. I unfortunately never had the chance or the pleasure to meet him. So a lot of what I'm going to be speaking about are things that I learned from Dr. Potenza, but also Wendy was actually very nice to send me a letter with kind of her thoughts on Dr. Hansbrough and his goals and his kind of how he viewed what he did. So hopefully this will give you an idea of what he was like. He was born in 1946. He graduated from the University of Wisconsin, which Dr. Potenza used to say was the best school ever, because that's where he went. He went to Harvard Medical School and did his residency at the University of Colorado. And he actually stayed there originally. He graduated from his residency about 1979, stayed there as faculty, stayed on as the burn director from 1980 to 1984, and then was actually recruited here by Dr. Orloff to be the director of the burn center here. While he was in Colorado, he actually was the director of 3 different areas. He started out as the director of emergency medicine, which back in the day was before they really had solid residencies, so surgery still kind of ran those departments in some areas along with medicine. He became the director of the SICU at about the same time that he was a director of the burn center. So he was a fairly busy man even back then. He did come here and was director of the burn center from 1984 until he passed away in 2001. So he was kind of the core person of the burn center here for many years. He had many academic accomplishments. One of his passions was research. Anytime there was any kind of problem that he would see, or even not a problem, just something he was curious about, he would create a project and go after it and write about it. He had about 188 peer-reviewed publications, 36 book chapters, 1 book. I actually found the cover of the book online. You can still find this on Amazon if you want to go back and take a peek. He had 3 US patents, one of which was for TransCyte, which was an artificial matrix that you could use on especially superficial burns to get patients to heal without having to do anything else really in terms of excisions and grafts. He had many research grants, all of which totaled at least $2 million. I actually have his CV and try to add it all up. He researched about everything. I was looking at his CV last night, and that very first article, this is his very first article, the one at the top. And if you're asking yourself if it's that Dr. Starzl, it is. They worked together while they were at the University of Colorado. And his first several papers were actually about biliary disease, liver transplants, complications of liver transplants. And then he finally, I think he knew his calling, but he kind of was starting out with Dr. Starzl as a mentor, and eventually moved to burn research. And he has published about probably every topic in burns you can possibly think of, and then things that we don't even look at anymore. He even looked at things like use of intravenous alcohol for prevention of withdrawal in alcoholic burn patients. We used to do this, we don't do it anymore. And he did things along with research projects with the community. So it wasn't just bedside or translational research, it was projects that involved with prevention and aftercare as well. He was very acutely interested in things that happen on the inpatient setting. Feedings, cultured skin especially was one of his big time passions, especially with his work with TransCyte. Thermoregulation, he was one of the first people to look at pentoxifylline in the lab. And he also started work on a national scale. He looked at burn registries. The ABA at the time did have a patient registry. It's not as extensive as it is now, but they did have a registry at the time. And he was also involved in multi-center trials to look at things like fibrin glue, which if you've been in my room or in the room in the last few years, you know we use a lot of now, probably more so than we did 10 years ago. But this was probably his baby. This is probably the thing that he loved more than anything else, is TransCyte. And this was a matrix that you could put onto burns and get them to heal. I'm told it worked really well. Unfortunately, by the time I got started, it was actually gone. A company had bought it, and then they got bought out, and the product never was continued to be produced. So fortunately, this is one of those things where the nurses who are from Hansbrough's day used to tell me all the time this stuff was great, and I'm like, well, that doesn't help me because it's not around anymore. He was also, one of his other passions, he had several, so one was research. Number two was his commitment to education. He trained 17 fellows in burn surgery, both international and from the United States. He did hundreds of national and international presentations. He was constantly traveling to do these things. And he also was the one that started the tradition of doing CD training videos. He actually got set up with his own camera and would start filming videos. And these videos actually went to not just within our group, but they actually went to the Navy. He would send these out to Navy training vessels who were being deployed so that they had some basic education on burn care, especially if they hadn't had it. So he would create these videos with the old, not digital cameras. I don't know if all of you guys remember that, but he would set it up, he would film, he would produce these things and copy them and send them out. He was also very involved in community outreach. He did a lot of paramedic lectures. He worked with the pre-hospital crew, both within the city and within the county. And as part of that, he also met with several of the city councilmen. This is actually Ron Roberts, who is one of the board of directors for the city council in San Diego, and managed to reach out to him and treated, I think, a family member, and kind of got to know him and was able to get some donations for the burn center through his many relationships that he had developed within the community. He was also and this is probably not last but certainly not least, was his dedication to the burn center. He truly believed that the burn center should be a community where you should be able to build a team. And it's probably one of the first areas in surgery that actually became more of a multidisciplinary specialty. This is not just about the surgeons. It's actually not just about the surgeons and the nurses. This is about the entire team. This is one of the first areas in surgery where you talked about having partnership with not just nursing and physicians, but also with respiratory therapists, physical therapists, occupational therapists, speech therapists, and even, especially in the aftercare, their role is probably much more important than what we do as physicians for these patients. He talked to everybody. He made everyone included. He apparently also would sponsor bowling parties and get-togethers at their house. My condo is not big enough for the entire unit, so that won't be happening for me, but the bowling get-togethers we'll talk about. And so he even talked to the guys who were out front valet parking the cars. He liked to get to know everybody and talk to everybody. So I think his legacy really is that he was kind of the all-inclusive, all-around, well-rounded researcher, educator, and leader for the burn center. And that's, I think, something that all of us should strive to be in all respects. And he, of course, couldn't do it without his better half, Wendy. She actually was the burn unit, the nurse manager for many years while Dr. Hansbrough was here, and I think even afterwards. So she certainly helped to contribute to his career, and if he was here, I think he would tell you that. So thank you all for coming, and that was Dr. Hansbrough. Now, normally Dr. Kornberg actually does this next part, but he had to unfortunately go out of town, so, well, fortunately for him. So I'm here also to introduce Dr. Kagan, who is our Hansbrough lecturer for this year. Dr. Kagan and I first met when I was a medical student, actually, at the University of Cincinnati, and then I did my intern year there and rotated on his service. He obtained his Bachelor of Arts in Chemistry from Case Western Reserve University in 1970. He graduated from St. Louis University in 1974 with his MD degree. He then did his residency training at the University of Illinois and stayed there as a staff surgeon in the Cook County Hospital Burn Unit in 1979. His passion for burn surgery started actually towards the end of his residency career when he was placed in the burn unit to do his research year, and it kind of blossomed from there. He was recruited to the Shriners Hospital for Children at the University of Cincinnati in 1988, where he became professor of surgery in 2003. And along the way, he managed several areas. He was the director of the Adult Burn Center from 1988 to 2008. He was assistant chief of staff of the Shriners in 2000, and he became the chief of staff until in 2004, until his recent retirement in 2015. He's currently an emeritus chief of staff for the Shriners Burn Hospital. And if any of you have ever had the chance to go see a Shriners Hospital, to rotate or work or even visit, I highly encourage it, because as I was telling some of the chief residents, it's how a hospital can function when basically no is not an answer when you need something for a patient. So it's an incredible place to work. During his career, he served as president of the American Association of Tissue Banks, as well as president of the American Burn Association. He's still on the editorial board of the Journal of Burn Care and Research, and he's a reviewer for several other journals, both in reconstructive surgery and in burns. His research interests are very diverse. They include not just burn care, acute and reconstructive, but also tissue banking, skin substitutes, burn center reimbursements, so we're talking about coding, and acute and chronic wound care. He has authored over 190 abstracts, 120 original peer-reviewed publications, more than 19 book chapters on burn injuries and tissue banking. He has lectured all over the world on various areas of burn care, and still continues to be a resource for the Shriners Hospital. I am honored to welcome our 2017 John Hansbrough Memorial Lecturer, Dr. Richard Kagan.
Thank you, everybody, for inviting me here. I haven't been treated this well in such a long time. It's kind of amazing. As you can imagine, growing up in Massachusetts, spending all of my educational years in the Midwest, and that's where I've remained. I went to the School of Hard Knocks at Cook County Hospital, where I started my training. We were admitting over 500 patients a year pretty routinely. I can tell you lots of stories about how ugly things were in 1974 when I was an intern in the burn unit. The attendings didn't come in, the quote fellows rarely answered their phone calls, and then you got a 70%er. And it's like, you call them, they'd say, well, just resuscitate them, I'll see them in the morning. That stuff happened. Thank God it's not like that anymore. I knew John Hansbrough. We were contemporaries. I finished my residency also technically in 1979, but did my year of research a little bit out of order. Most of you go into the lab after your second year. I was prepared to, not knowing what lab I was going into. And one of my resident fellows, one of my best friends actually, who was a year ahead of me, who was in the lab, was diagnosed with Hodgkin's disease. And they said, we want him to stay in the lab, get his treatment and recover, so go ahead and finish clinically, and we'll have you do your research at the end, which I thought they'd never do. Well, they did. For advancing, is it just the arrow? Okay. So first of all, let you know that I have no financial relationships to disclose, but I am going to talk about an investigational device, the engineered skin substitute, that, as you heard, was developed by Dr. Hansbrough and Dr. Boyce, that first started out in Colorado, moved to San Diego, and then my predecessor, Glenn Warden, who was the chief of staff at the Shriners Hospital, 4 months after he recruited me, recruited Dr. Boyce to Cincinnati. And I'm going to spend the second half of my talk telling you about how that worked for us. This is an important point for you. Dr. Olga Jonason, who was the first woman to chair a department of surgery in this country, was the residency program director and my mentor. Not only did she interview me in the transplant clinic, but when I came in middle of June and started to move into the Chicago area, she remembered my name. She remembered my face. I wish I could say I've done that. I could do that with people that I interviewed for residency. And it was, hi Rich, you ready to go, blah, blah, blah. We kept very close. She mentored me like no other mentor. She was the surgeon that if a resident came in and needed an operation, they'd say, don't look at the call schedule, call OJ. That was what we called her back then, before OJ meant something else. She was also called the BW because she's a big woman. She was 6'3", and she looked down on everybody, literally. So when it got to my January of my chief year, she said, so what are you going to do your research in starting in July? And I said, I don't know. And she says, well, it's Friday. Meet with me at noon on Monday, and we'll go over what we're going to do. So, of course, I went home, had a wonderful weekend, not thinking about anything, came back to her, and she says, great, you're going to do your research in the burn unit at Cook County. I've already arranged for everything for you to get started, and we'll just keep going. And during the first 3 months, I was more focused on getting my research started, passing my boards. As soon as that happened, I started taking care of patients in the burn unit, because all the nurses were the same ones from when I was an intern 5 years previously. And then Dr. Jonason said, why don't you come around a general surgery service with me over at Cook County Hospital too? And in those days, it was a lot of fun. We were doing 5 ulcer operations a week, parietal cell vagotomies, B1s, things that you guys only read about in books. And then in '88, after I completed the American Burn Association Traveling Fellowship, one of the places I'd been was Cincinnati, the Shriners Hospital. And Dr. Warden called me up and said, how'd you like to come to Cincinnati, run the adult burn unit, and work with us here at the Shriners Hospital? Which, if you're a burn guy, that was Mecca. Unfortunately, the other competing factor was Dr. Jonason was going to Columbus, Ohio, and wanted me to come and run the burn unit there. And so I was in a little bit of a dilemma, and I called some friends, one of them, Cleon Goodwin, who was at the Brooke Harvey Burn Center for many years. And I said, Cleon, what do I do? He said, Olga will take care of you and protect you for as long as she's there, but she's the first woman surgeon in this country in a place that she's probably not going to survive more than her first 5-year appointment. And I'd go with Glenn, and don't worry about Joe Fisher, he'll come around. And so I went to Cincinnati, and even she agreed it was the right move in retrospect. Hard thing for her to say, but when a mentor looks over your shoulder and says, I think you have an aptitude for, don't blow it off, because I never had thought about a career in burn care at all till that day. And I wish, if I had to do it all over again, it's exactly what I would do. So for those of you who don't know much about the Shriners Hospitals for Children, we're a little bit of a bastard stepchild to St. Jude that everybody knows about because they can put a picture of a bald child getting chemotherapy, get tears, and get your donations. The Shriners Hospitals, however, have been around since 1922 when they first opened their first hospital in Shreveport, Louisiana, the primary focus of which was the treatment of polio. And they expanded to the point where they now have 18 orthopedic hospitals, ranging from Mexico City to Honolulu. Nice place to work if you want to be an orthopedic surgeon. Pretty much scattering the country. Many of their places are standalones. Some of them are in academic medical centers. The burn hospitals didn't come about until the early 60s to mid 60s. One of the Shriners felt that there was an unmet healthcare need for the treatment of children with burn injuries. And so they began by looking into operating burn centers with a focus on pediatrics. And currently there are 4. The Boston Hospital, which is right across the street from Mass General, the Cincinnati Hospital, which is part of the UC Medical Center, and also across the street from Cincinnati Children's Hospital, which, by the way, does not and never will have a burn unit. The Galveston Hospital, which is run by David Herndon, which is part of the UT Medical Branch system, and the Northern California Hospital, which opened in 1997. It was the most recent, and when they built that hospital, they said, let's build all 3 of our specialty service lines in there, so they do orthopedics, spinal cord, and burn injury in that facility. So this is what they look like. Again, they were built beginning in the 60s. All of the hospitals, with the exception of the Northern California Hospital, built in 1997, were replaced in the early 90s at a cost of an average of about $40 million each. The burn units are all about 30 beds. The hospital in Sacramento is about 80 just because of the diversity. Our hospital in Cincinnati began under the leadership of Bruce McMillan, but the person who decided to take on the burn interest was Dr. William Altman, who was the chairman of surgery at the time. So in 1964, the old Cincinnati General Hospital, which is now University Hospital, began to house 7 beds. And then in 1968, Dr. McMillan took over the burn center until Dr. Warden succeeded him in 1985, and then when Glenn retired in 2004, I applied for the chief of staff job, primarily because all of the other applicants had never worked in the Shrine system, and I said, my God, I'm gonna have to train my boss if I'm not the boss. So that was my excuse to my wife for why I applied for the job. That and the fact that I'd already been there for quite a while and knew the system. So what are some of the important things that have happened over the course of the 45 years that the Shriners have been around? I've been practicing for 37 of those years in burn care. And so we began to see earlier referral to burn centers because community hospitals were keeping these kids, even the adults, to the point where they only thought about transferring when the patients were septic. Fluid resuscitation was evolving to the point where people were thinking about resuscitation and not just following a cookbook formula. And there were a number of them out there. We began to look more closely at nutritional support just because of the extreme catabolic effects of extensive injuries. We began to rethink burn wound management. In 1974, when I was an intern, patients got tubbed 3 times a day. When they screamed, they threw a milkshake in their mouth, and the place smelled like a burn unit. There was moaning. If you walked in on the first floor and the burn unit was on 5, you could tell there was a burn unit in the building. The odor emanated. I remember I lost patients who were 30 years old with 30% burns because we weren't doing much about the wound, except if they got 3 weeks in and they were all granulating, then we started to graft them. That was kind of our Darwinian approach. If you survived to get grafted, you had a chance. It was kind of bad. But when I came back in 1979, as part of my research time, they were doing early excision, and mortality rates were just plummeting. So we saw improved survival, and this was the beginning of thinking, if most of these patients are going to survive, we really have to start thinking about not survival as the outcome factor, but what about their afterlife? What about their physical and psychosocial rehabilitation and societal reintegration, which is probably one of the major foci of research now in burn care. So a little bit about our hospital over those years. Now you got to realize this is a 30-bed pediatric burn facility, over 30,000 admissions. We did 2,000 transports, and I'll tell you a little bit about our transport team. We actually sent an ICU nurse and a respiratory therapist out to other hospitals, stabilize the patient, bring them back. You notice I didn't say we sent the physician. We never sent the physician unless the transferring physician insisted we send somebody. And usually we'd send the second-year resident and say, just do what the nurse and the respiratory therapist tell you. Show them your MD to make him happy, get the kid out of there. We had a lot of admissions for reconstruction, which really appealed to me because early on in my training, I wanted to be a plastic surgeon, but I didn't want to do cosmetic surgery, which was starting to come into play. I wanted to do the good stuff, the stuff that really mattered to patients. And so here came an opportunity for me to do reconstruction because as these children grow, they outgrow their skin, their scars, and a lot of reconstruction for function and cosmesis became important. A lot of outpatient visits, about 3,000 or so a year. And you got to realize, we're in Cincinnati, Ohio. Our treatment area within the Shrine system was 22 states. So if we had a kid who was from Tampa, Florida, and he had to come back for a clinic visit, the Shriners bought them 2 plane tickets. Mom and Dad, they picked them up at their home, took them to the airport, somebody picked them up in Cincinnati, drove them to the hospital, fed them, clinic visit, and a home at no expense to patients. Something that I'd never experienced before. A lot of outreach visits. At one time, we would have hundreds of patients within a large city like Tampa. Rather than paying for 200 plane tickets for clinic visits, we'd kind of lump a bunch of patients together, send a doc, a nurse, a therapist, and there was a team down, and over a day and a half, they'd see 130 patients. And so we did a lot of those. And then we began doing telemedicine as that evolved, and the Shrine is looking into using telehealth because a lot of what we do in burn care is looking at the patient. It's a lot less touching. And so we found that we were able to provide acute treatment through either the Shriners' temples or the other Shriners' hospitals and reduce the costs related to transportation, be able to give the same advice through that mechanism. Over that period of time, we had over 8,000 acute burns, mean age about 6 years, mostly boys, not surprisingly. Over that extended period of time, patients were referred on average about 7 or 8 days post-burn, but I'll have a slide in a little bit that shows you how that changed over time. The average burn size was 16%, with about 10% being third degree. That compared to a national average that was much less than that. So the Shriners Hospital were getting bigger burns, referred to them in deeper burns. Inhalation injury was and is still about 7% in the pediatric population. And the length of stay was about 1 day per percent burn, which has been something quoted for a long, long time, 1 to 1.5 days. And overall mortality during those entire 45 years, 3%. So let's take a look at some of the decades of treatment. I think the most notable thing, if you look to the far left, is the fact that in the first years that the Shriners Hospital opened, Most of the patients were being referred close to 3 weeks out from their burns, which meant they were coming in pretty sad shape. As the word got out and we started communicating more and more with other hospitals, local community hospitals, hospitals within the regions, doing a lot of outreach teaching, the referral days started to the point where if we got a call about a 90%er, that kid was probably in our door within 36 hours. And you can see over the years how that dropped. The age stayed about the same, still 6 or 7 years old. Something else that we also noticed, largely through burn prevention efforts that the Shrine promoted, was that the size of burn was dropping very drastically to the point where last year, our last few years, we've been down to about 10% burn, whereas in the early years, they were much, much greater than that. And I used to jokingly say to Dr. Warden, I say, if we do too good a job with burn prevention, we may put ourselves out of business. And to some extent, that's kind of happening, because people working in burn centers now don't see as many 60 and 70% burns as I did. My first weekend on call at Shriners Hospital, the average burn size in the unit was 50%, and I had 11 kids on ventilators. You don't see that anymore, anywhere. But that's a good thing. So some of the improvements that came from the Cincinnati Hospital, we were the first hospital in the country, and I think the only, to have a CAMT certified pediatric burn transport team. Every time our team went out, the patient was hemodynamically more stable, more thermodynamically stable than they were when they came in by other routes. And even in the later years, we found that if the other hospital had called a critical care transport team and said, we have somebody on the ground that can bring them to you faster, they would always come in less stable on stuff that they shouldn't be on, and almost always somewhat hypothermic. And so we really found advantage in that. And then the Shriners Hospital expanded the use of our team to transport some of the spinal cord injuries from hospital to hospital as well. But unfortunately, with big burns dropping down and less need within the Shrine system, they ended up disbanding the transport team, primarily because of staff reductions, because of fewer admissions and the like, and we just couldn't maintain a team. And actually, there was also the benefit that if the other hospital called a critical care transport, they picked up the tab and not us. Wes Alexander was another of my mentors who's still alive in Cincinnati, primarily known for transplantation, but a huge effort in immunonutrition and burn care. And he was the one who essentially led us to drop a feeding tube right after the central line is and start feeding them immediately during burn shock resuscitation. We got real good at infection control. There isn't another unit in the hospital where people glove and wash their hands and wear gowns more than in a burn unit, and where somebody will slap your hand if you don't. Whether you're a resident, whether you're attending, the nurses will say, come on, wash your hands. And for that reason, every time I needed an operation when I was in Cincinnati, I said, post-op, I'm going to the burn unit. And they'd say, why? They got lots of bad bugs. I said, yeah, but everybody washes their hands. So, great place. We use high-frequency percussive ventilation as a modality. We found it to be very, very effective in the management of children with inhalation injury, because it really was good at mobilizing the secretions, the like that came about from the pulmonary injury. And again, we used the idea that early excision that was pioneered by Jack Burke at the Boston Shrine Hospital, Mass General, was the way to go. There were a lot of people who were naysayers. Even Dr. Pruitt, for many, many years, felt that doing early excision was a signal of death for the patient. In fact, he told me that on rounds as a visiting professor. I told Janine, I said we had an 83%er, I had him excised and mostly grafted, and with rounds, and Dr. Pruitt looked and said, Dr. Kagan, you're operating on this patient so aggressively as consigned him to death. And thank God Dr. Jonathan was there and says, oh, Basil, that's such poppycock. So I kind of felt vindicated, but that was the way things were. And I think as a burn surgeon, I quote my predecessor who used to say, you can learn 80% of burn care during a burn fellowship. It'll take you the rest of your life to learn the other 20%. You're learning all the time. You're getting better. You're getting more aggressive. You're learning what things you can do. Like John Hansbrough, I got really involved in tissue banking. I actually started and then ran a skin bank in both Chicago and Cincinnati. and got very involved in the American Association of Tissue Banks for setting up standards, protocols, and actually I learned really well how to take skin for skin grafts, because I used to go over to the Cook County morgue and harvest the skin myself. And when you're doing 200 donors a year, you get real good at handling a dermatome. And we found that if we could preserve skin by keeping it in nutrient media at room temperature, that was better skin than frozen skin that was cryopreserved, because it would become viable, it would vascularize, and be a much more effective temporary wound cover. We began to do sheet skin grafting, I'll talk about. That's unmeshed grafting, to the point where a 30 to 40% burn, if there was adequate donor site within 2 operations, we would do all sheet grafts, no mesh grafts. And I'll show you a little bit about that. Our anesthesiologist noticed that the kids had a lot of pain from their donor sites post-op, needed high narcotic. And they said, you know, why don't we try putting something in the fluid that we inject beneath the donor site? So we started adding originally bupivacaine, and recently switched to ropivacaine. And the kids were waking up with no morphine requirements at all, because it would stick around in the donor site for quite a while. And so these were other things. We just kept, it was, like Gene said, the team, we all rounded. We all talked about stuff in the office, in the hallway. We listened to the nurses. And we really started to get good at this thing. And we got better every year. I used to also say, if we're still doing what we do 5 years from now, what we're doing now, we haven't made any progress. We have to keep changing to get better. I'll talk a little bit more about the engineered skin replacement, and again, the importance of close follow-up for burn reconstruction, primarily to main function, but as lasers came along, to try to improve cosmesis as well. So here's a 4-panel slide of some of the things we found with the high-frequency percussive ventilation. Regardless of survivor or non-survivor, we found that the peak inspiratory pressures were significantly lower with the high-frequency percussive. In the top right panel, the P to F ratios were much better. On the bottom left, ventilatory efficiency is measured by P to F divided by PIP. But probably the most important thing was the drastic reduction in barotrauma. It wasn't unusual for us in those days to have kids with 3, 4, 5 chest tubes with bad inhalation injuries. And with this, we saw almost no pneumothoraces, we saw no pneumopericardium and the like. And this was a mainstay, primarily because it was for keeping the airway clean. Back in the days, if you had a 2-month-old, there wasn't a pediatric scope that you could do anything with. Even if you got the spaghetti-sized scope, you couldn't suction through it. So this was huge. Not surprisingly, because of better burn care, as well as the reduction in size of burns, survival increased to the point where it was close to 99% when I left. It was rare for us to have a death in any given year if the patient either didn't come in septic or wasn't close to brain death. Length of stay dropped precipitously. Again, partly because we were very aggressive with the excision and we weren't having to do as much surgically as far as the extent of burn. So here's the operative strategy that I think most of us use nowadays. For small to medium-sized burns, under 35%, you're almost always going to have sufficient donor site. And you can excise them in 1 to 2 steps and autograft them. Usually you don't have to allograft them unless there are other mitigating circumstances, like if they're in severe ARDS, you may just want to allograft them, get them hemodynamically stable, get them down on the vent, and then bring them back and do the autografting electively. In the cases of the bigger burns, you excise them in multiple stages, although our philosophy was all the full thickness burns had to be off within 7 days of admission or sooner. We'd use their available autograft, cover the remaining areas with allograft or Integra, and a skin replacement, dermal skin replacement, and then use skin autografts. It sounds real simple. You know, if you think, well, 90% burn has 10%, so all he really needs is 10 skin grafts. Not true. Some of that 10% of, quote, donor site might be the face, might be the scrotum, might be the soles of the feet. So when we actually mapped out our burns, we actually mapped out what's the available donor site, so we could put a number to it. So one of the things along the lines of thinking about skin substitutes is, do you want a skin substitute, which is really temporary, or do you want a skin replacement, which is permanent? So you have to think about permanency, the rate of engraftment. You don't want to put something on the wound that has only a national 30% take rate. It's just not going to get you anywhere. The need for reapplications, which imply going back to the operating room, more anesthetics, more time in the hospital, and ultimately cost effectiveness. So this is a list of some of the common things that are available, ranging from BioBrain, which very few of us use nowadays except occasionally on a donor site, all the way down to Epicel, which is the Genzyme product, which is the one that's currently available, and that's per 100 square centimeters. Well, a square foot's about 1,000 square centimeters, so multiply those numbers by 10. An Epicel would cost you $24,000 a square foot, approximately, with a 30% take rate. And then you get down to the skin that we developed in Cincinnati that started again here in Colorado and with John here in San Diego. We estimate would cost about $30,000 a square foot, except the take rate's probably around 90 some odd percent. And it's rare that you have to regraft those areas. And I'll show you some photos of that. So we think about options for wound coverage. Fresh human allograft skin is number one. Integra might be number two, depending upon the wound. And third, I would always put cryopreserved allograft skin. This is for excised wounds, where you've got dealing with fat or fascia as the wound bed. The others, I don't think really have a place because they're just not effective wound covers. And here's an example of the difference that you'll see. The left panel is frozen cryopreserved. This is a 1-year-old with a 35% scald, severe ARDS, trached on his way to get ECMO, which we are lucky enough to save and bring him back and replace the allo with auto. The child on the right, also severe inhalation injury. You can see his trach, that was sheet allograft at 5 days. He happened to have 6 chest tubes in at the time. He got better once his wound was temporarily closed, and then we brought him back and replaced the allo with autograft. So a huge thing for us. And here's the Integra dermal replacement, which just doesn't have the resilience. Skin is used to bacteria, even allograft skin. This stuff that was developed by Dr. Burke, if you had a scintilla of a bacterium anywhere near this stuff, it'll get infected. And again, at the cost of it, you gotta be very careful when and where you use it. For permanent wound closure, obviously it's autologous skin. For small burns, we'll excise and close an area, defat the skin, and use a full thickness skin graft with minimal donor site morbidity. We'll do split thickness sheet grafts, and if we have an extensive burn, we'll use mesh grafts, but we will always sheet the hands and the face, always, even in the 90 percenters. And then the various engineered component grafts, such as Integra, which really was a major breakthrough, but with somewhat limited application. I think it's finding more sources. So here's a patient who came into the adult unit with electrical contact burn. This is what, on the left, what his hand looked like the day he came in. We washed him off. It was clearly full thickness. Wasn't going to get any less deep. So the next day we took him to the operating room, did a full thickness graft, and sent him home. He was back to work within 3 weeks. You don't need to sit around and wait on these small ones. Very effective, no reconstruction necessary. And then Glenn and a number of my colleagues published a paper on our use of the sheet autografts that I mentioned before that we would do exclusively on 30 up to 40%, depending on what donor sites were available. You know, in burn care, a good burn for the surgeon is one that spares the thighs and the back, but the face and hands are burnt. The good burn for the patient is the torso is burnt, but not the face and hands. It's like, well, those were my donor sites that got burned. But we found overall that they had superior cosmetic results. The face and hands, as I said, are prioritized. Less time in pressure garments and a much better cosmetic score. Much less scarring as well. And here are a couple of photos of some children that we operated on. The top left panel is a day 5 photo. The bottom right, I think, is a year out. That's a pretty nice looking result. And this is even before we had lasers. This is an adult patient I took care of who'd had a grease burn to the dorsum of his hand and wrist. The top right panel is a deep 2nd degree burn, as indicated by the whitish yellow in the top left panel. The top right is 5 days post-grafting, and the 2 bottom panels are 1 year out with wearing pressure garments and massage. Pretty nice results. And some people have said, well, where'd you do the graft? Well, that's a good sign to the burn surgeon if somebody can't tell where you grafted. I mentioned that part of our permanent coverage armamentarium are the cultured epithelial autografts. The potential advantages are permanent skin coverage when you have insufficient donor sites and covering a larger surface because you only need a small biopsy, maybe a 50 square centimeter split thickness biopsy. The controversy that's existed ever since the technology came out is whether or not it really reduces the number of operative procedures because of the poor take rate, whether it really shortens hospital stay, and whether it's cost effective. The two photos that I have for you are a patient who is treated at a nearby hospital and referred to us a year post-burn. The left panel is 1 year post-burn, showing his unstable skin and scar. The one on the right is 2 years out. And at one point in time, the child and mother said, "This stuff breaks down so much, what can you do?" We ended up cutting off a lot of that cultured skin and grafted it from his never used donor site of his back. The surgeon never used available donor site. So I don't think any of us would consider using this nowadays, except in a patient with greater than 85% full thickness burn, and obviously limited donor sites. The cultured skin that we're using was developed, as I said, by Dr. Boyce and Dr. Hansbrough. It was initially approved for extensive full thickness burn reconstruction, and interestingly for congenital hearing nevus. It is a bilayered skin substitute. It has epidermis and it has dermis, which is very unlike anything else that's out there. It takes about a month or so to grow, and it's best applied to a dermis or a neodermis, such as Integra, although we have placed it on fat and fascia for quite some time. So here's an example of what we would do in a typical patient. The red areas are full thickness burn. The other areas are potentially available donor site. So the first thing we do at the very first operation is do a split thickness skin graft biopsy of about 50 square centimeters, isolate the cells, the keratinocytes, the melanocytes, the mesenchymal cells, and the human fibroblasts. And right around the time of that, we're excising and grafting the hands with sheet from the available donor site. And Dr. Boyce is working along and placing things on the biopolymer substrate, the keratinocytes and melanocytes on top and the fibroblasts on the bottom of the substrate. And while this is going on, because weeks are rolling by, we're excising and mesh grafting the lower extremities. We're using the donor sites as they heal because we got a month to get busy and also to plan where we're going to put the skin when it's ready. And sure enough, the skin is brought to an air-liquid interface. It's ready in about 30 or so days. And now it goes on as the 6 by 6 centimeter sheets. From that 50 square centimeters, our lab could produce 1 square foot at 1 month, another square foot a week later, another square foot another week later. And we used to say to ourselves, boy, if they could just have the ability to grow 4,000 square centimeters at 3 or 4 weeks, we could excise the whole front, cover it all with cultured skin, wait a couple weeks, do the same thing for the back. And maybe we'll get there someday. This is what it looks like. The top right panel is a typical example of it. You can't see through it, but if you take it off the gauze, which I occasionally did, you could actually see the epidermal barrier. You could see the dermal side. You could place it on just like a 10,000th of an inch skin graft. This is some photos of us removing the silastic from the Integra on the top right panel. The wound bed, dry as a bone. That's before we put anything on it. That's the Integra prepared wound. That's the neodermis. There go the squares of skin, some dressings with irrigation catheters for infusion of topical antibiotics. And at day 7, you have a glistening wound with epithelial barrier. By day 28, you actually have healed skin that you can actually massage with moisturizing cream. The first 54 patients that we did, funded through Shriners and the FDA, average age of 7 years, the average burn size 74% body surface area, almost all of it full thickness. The percentage of body surface area that we were able to cover with the cultured skin was almost a quarter of their body, and that was limited by the fact that the lab could only grow so much at any given time, and the size of the laboratory and their facilities. And the number of days till their first graft was, again, about 30 to 35 days. Our engraftment from the entire period compared to autografts, our autograft rate was 95%. In our institution, any graft take of less than 95% had to be presented at an M conference. Not 80%, 95%. Early on, we had some issues with take. I can tell you, in the last 10 to 12 patients we had, they were generally well over 95% take. The other thing, if you think about it too, is most of us, when we think about meshing skin grafts, about the widest we'll mesh is 4 to 1. It doesn't really give you 4 times, but it's about 4 to 1. If you think about what this does, this is the equivalent of a 60-to-1 expansion with a sheet graft, because these are not mesh grafts that you apply. So it makes a huge difference in our ability to cover wounds. The percentage of body surface area closed by day 28, about 20% was cultured skin, and 50% was autograft of the 70%. And obviously, the bigger the burn, the more cultured skin was applied. This is an example of a 18-year-old who came with an 81% burn. Of those areas, you can see in green the areas that we split thickness skin grafted, and the cultured skin was all of the rest of that. This child walked out of the hospital in much less time than he would have had we had to wait for donor sites to heal. These are some shorter-term follow-ups. You can see the hypopigmentation in this African-American child by day 28. Here he is on the right panel at day 479. And you can see the scarring in the mesh autograft over the left scapula, whereas the cultured skin doesn't really have that. There are issues, as I said, with hypopigmentation. And here's another patient, a Caucasian child, where you really have a hard time distinguishing at about a year out which is autografted and which is the cultured skin. Very pliable. Again, you can see in this photograph as well, the skin is soft, smooth, pliable, but again, the issue of hypopigmentation is present. And the other interesting thing is, based on Vancouver scar assessment, that the cultured skin actually had less scarring from the outset, even out to a year post-burn, when they kind of caught up with each other. Here's an example, some slides of a patient I took care of with one of our plastic surgeons, a child with congenital hairy nevus. They had done the left side of the back with donor site from the scalp. And I said, well, why don't we try the cultured skin thing? And so we brought in the child, did a biopsy, excised and allografted the wound to prepare the wound bed. And then a week later, when the skin was ready, because this was all planned a month in advance, we applied the cultured skin. Here she is on the right, 5 months out from her cultured skin. Here she is 8.5 and 13 years out and has never had an operation subsequent to her cultured skin grafts, which is pretty amazing when you think about the growth that you get in that, and the fact that she refused to come back to clinic so I could take more pictures of her. I know you won't be able to read the panel on the left, but we had some issues with an FDA integrity hold issued to the university in the process, which limited us to compassionate use. We were able to enroll 16 patients during that time with an average burn of about 78%. Of that group, we had one mortality, and that patient died before the cultured skin could be applied from complications from inhalation injury. And the right panel shows our mortality rate compared to the National Burn Repository's mortality rate for children in that age group with that extent of burn injury. A huge difference from 30% to under 10%. So we think not only is it effective for coverage, shortens hospital stay, and by shortening hospital stay, it probably covers the cost for the skin if we were to have to pay for it, because it costs about $10,000 a day for a burn patient to be in the hospital. Here's what's happened to burn mortality. If you go back to the 40s, before penicillin, the LA 50 was around a 30% burn. In the late mid-60s, by then we already had broad spectrum antibiotics. We had refinement of fluid therapy that came out of the coconut growth fire in Boston from Dr. Oliver Cope. Dr. Fox developed Silvadene and other topical antimicrobials in the 70s that helped. The problem was these only got the patient to the wall. The wall was the wound. If you couldn't deal with the wound, they were dying, well resuscitated and the like, but you hit the wall. And so in the late 70s, we began to do early excision and temporary closure, as well as aggressive autografting. We got real good at critical care, although most of the burn doctors in this country of my age didn't get critical care boards, didn't get critical training. Many of us didn't even go through a formal fellowship. It was OTJ, and you just learned as you went. And then we got the engineered skin. Our LA 50 at our hospital got up to about 98% for a 50% burn would walk out of the hospital. And we had many 90, 95%ers who walked out of the hospital, went to school, participated in sports and the like. It's an amazing thing when you can think about the fact that a 30%er had a 50% chance, and now a 95%er has probably a better than 50% chance. There aren't too many specialties that can claim something like that. So in conclusion, I think Children with acute burns have benefited significantly from improvements in burn care at our place. And I think as a consequence of Schreiner's research, other burn centers, including adult burn centers, have gained a lot of knowledge as well. The decrease in mortality, as I said, is not only due to decreased incidence of extensive burns, but improvements in all aspects of care. Burns of the head and hands, I think, are cosmetic and ought to be covered with sheet grafts whenever possible. And engineered skin replacements are going to have a huge role. They reduce donor requirements, which is a big deal for a lot of patients. I wouldn't use it in a 10% burn, but I think it has an important role. And we're going to find that, like many other things, that as people get more familiar with it and begin to look at cost-effective issues, it's going to have a huge role in the treatment of things like congenital peritonitis. It might even have a role in curing epidermolysis bullosa. We'll have to wait and see. Obviously, improvements in burn care are only going to come about if people continue to have a strong interest in research. There aren't too many burn guys in this country that don't have some notion of research, as do their dietitians, their therapists. Everybody is thinking about how can we do a better job, and we talk to each other. We are a team, we are a family. You go to the American Burn Association meeting, it's not docs. That's only about 100 of the attendees of the thousands, 2,000 or so that attend. There are firefighters, there are burn survivors, there are social workers, psychologists. It's the whole thing. And when you're a physician, you say, you know, I'm not just a surgeon, I'm part of a huge team. I'm the leader of a huge team, which means you have to listen to everybody, because you're not going to get better unless everybody gives you input. And you walk out of there every night exhausted, feeling like this was a great day. And when I walked out the door when I retired, it's like, I'm going to miss the people that I worked with, perhaps more than anything else, because you become family. Or as my wife used to say, well, which is your most important family? And I'd say, when I'm at work, it's them, and when I'm home, it's you. So I'll stop there and take any questions you have. Thank you very much once again for the invitation. I've been treated like royalty, and I got to go home. My wife, who hasn't seen a lot of me for the last, whatever it is, 25 years, has to now see me every single day. Thanks so much.
I have one question. So there haven't been a ton of advances in burn care. There have been several that you pointed out. What's the next big thing that you think that we should go at?
I think Dr. Coimbra and I talked about it yesterday, and that is, where's the next generation of burn doctors coming from? Where is that expertise that I got from what I call the Brookies, if you will, or the Charlie Baxter disciples and the like? We got it from their guys, and now my generation is slowly beginning to retire. We're actually rapidly beginning to retire. And the question's going to be, who's going to be able to lead and to push you to think out of the box? You and I were talking about it yesterday. It's like, who's going to be the person to teach you that you don't have to do just a so-and-so, a limited excision? I mean, when I started out, I was doing no more than a 10% excision. When I left, I would do, if a patient had 80%, I was doing both upper and lower extremities. I was doing a 70% excision. But I was using tourniquets, I was using sub-Q epinephrine, I was using all these other tricks I learned. I had a great anesthesiologist who the curtain was down. We were looking at each other, talking the whole time. Contamination isn't a real big issue. You're dealing with a dirty case. But the communication was huge. It's like I told you, I wish I could teach you my tricks. And I wish I would hope that there would be people there to teach the tricks. It's just there's fewer of us left. You know, if you went to Cincinnati now because the census is lower and they have fewer big burns, it's like, how long would you have to be there to learn the tricks? Even my successor, she wasn't near as aggressive as I was. And I don't know without somebody being there that she'll get more aggressive and get more progressive and take, I wouldn't say more chances, but do a little bit more. Keep pushing yourself. Keep working with the nurses. I mean, our nurses kind of dropped off in terms of research because staffing changes and the like that happen. It's like now you got to kind of push them into doing something. You know, I think the team isn't going to survive without leadership, and the leadership's not going to grow without an infusion of new blood where they can get mentoring. For me, if I hadn't gone to Cincinnati, I can guarantee you I wouldn't be as good a burn doctor as I was when I left. A lot of it was mentoring. And John and I would argue all the time about stuff. We were contemporaries. We'd argue about the trans site. I told him I didn't think it was any, I at least told him it's way too expensive for what it does or doesn't do. And we'd go back and forth on this stuff. But you had this dialogue of people that were always looking to improve. For me, the American Burn Association isn't going listening to papers. It's being there to support my team who are presenting papers, helping them prepare for their presentations, and for me to pick the brains of some of my colleagues in burn care and say, well, how do you do that? And I'd come home and say, I think I'm going to try that. But I think leadership in burn care and experience in burn care is going to be huge. I think places like here, where you have integration of the acute care surgery, critical care program, and trauma with burns is good. I think that's much better than what I see in many hospitals, which is the intensivist plastic surgeon thing, where you have the two wheels working like this. The intensivist comes by, and probably the intensivist has no training in burn care, has probably never seen a burn patient in their life, and the plastic surgeon just takes care of the wound. You need to have somebody who brings the whole team together. That approach worries me. Cincinnati Children's, as I said, the 300-pound gorilla, 800-pound gorilla in town. No burn unit, pediatric critical care training program. Every year they'd ask me to come over and give them lectures on burn care because they said, some of us are going to go work somewhere. We might have to take care of a burn. We've never seen one before. I try to get them to come over for rotation, but it was always hit and miss whether they would see a patient. So oftentimes I just call them and say, you want to send somebody over? I just got a new admission. You want to see how resuscitation works? And I call them back and forth. That's the thing that scares me the most. And I saw this coming 20 years ago. When I looked at the American Burn Association listing of all the burn center directors, I knew who they were. I knew how old they were. I said, my God, we're all going to be retiring in 2010 to 2020. And David Heimbach at Seattle, who had a big burn fellowship program, says, well, I'm turning out a fellow every year. I said, you're not turning out enough. We've still got about 120 to 130 burn units in North America. And a lot of places are going, where are we going to find our burn doctor? And the trauma people are shaking in their boots going, oh, don't make me do that. And the plastic surgeons really don't want to be involved unless somebody else is taking care of the sick part of the patient. So for me, it's leadership, mentoring, and maintaining that special skill set in burn care. I remember when I interviewed for the American College of Surgeons in downtown Chicago, and in those days, every chief of surgery was a big shot in surgery, from the University of Chicago, Illinois, Northwestern, Loyola. And I'm interviewing, and one of the guys says, so you're doing burn care, huh? And I said, yeah. And they said, do you like it? And I said, yeah, I really do. And they said, that's good, because I can tell you, not a single person in the room wants to trade places with you. And I think that kind of is true today. It's the old, I admire you for what you do, but I wouldn't want to do it. So I think that that's a big piece in all this, is having that knowledge, that mentoring, that skill set, that when you do get that big burn in there, you're going to be comfortable being aggressive with it. Not just in the critical care management, as you guys are doing with that one that came in the other day, but you got to get the wound off. You got to get stuff on there. You got to get them covered. And you're going to have to scare some anesthesiologists. One of the things that we also did is we established intraoperative continuous tube feedings, nasoduodenal. We told our anesthesiologist who was afraid to do it, we said, let's do a study. We'll show you how safe it is. So we studied about 60 consecutive patients. We used NG tubes, and we didn't have a single episode of aspiration, whether we flipped the patients prone on their side, no matter what we did. And he says, I guess it's pretty safe. We'll publish it and we'll start doing it. So we've never stopped tube feedings, and our patients maintain their weight. They maintain their albumins without albumin infusions. They're healthier. We protect their gut, if indeed that's part of the issue. They heal better. Donor sites heal much faster when they're in a positive anabolic state. So to me, that's the thing, is where's going to be the leadership that you see in trauma critical care? Are we going to see that continue in burns like we did in the post-Vietnam era, where all the guys that went into the Army on the Berry Plan and the like came out, ran burn centers, recruited people to be like them, and trained them? I was able to train about 5 or 6 burn fellows in all my years. We usually didn't get applicants. About 80% of them are running burn centers now. Some of the others just went their other ways and went other specialties. I think here you're in great position. You've got a great staff. You've got a young surgical scientists who are interested in doing the burn service. That's a good thing. But as I told you, I worry. I wish I could bring you to Shriners while I was still practicing and show you, let me show you how I do this. Because there's a wow factor to that. You mean you can do that and it's safe? Yeah, I can do a 70% excision on a child and lose less than any of the blood. So that's my biggest concern, I think.
Thank you very much, Dr. Kagan. It was an extraordinary experience. Kind of getting back to the M&M case, the issues of persistence. Obviously, what you show over a long period of time at the University of Cincinnati is really the value of incrementalism in terms of making a real advance. You know, it's infrequent in our diseases and the things that we treat that you hit a home run. And it's a matter of, just repeated persistence, tackling each new challenge. And clearly over time, what a remarkable experience.
I was going to say, it's interesting because when you have a 90+ percenter, you're fouling off hundreds of pitches with 2 strikes on you. There are kids that are on DNR lists and all this stuff, and you just stay with it and you stay with it, just like you guys did on that last pseudocyst case. But it takes the entire village. Occasionally, it takes a couple of consultants to come in, which is pretty rare in burn care, actually, for children. So you're right. It's everybody has to care about improving, and everybody has to be willing to call the attending on something and say, I have an idea. That happens in burn units.
The question I have is, how pervasive is the use of the cultured skin substitute? What I kind of gathered from your talk is basically you produce it locally. But how kind of portable is the technology to make the grafts, or is there an industry option that does that for centers that don't have it on site?
So the story of that is it is not available. When the FDA required us to complete an audit that was outrageously expensive between the university and the Shriners hospitals, they decided that's the end of this. They closed the lab, which was costing them $500,000 to run, when we didn't have as much need as we had 10 or so years previously. We did have issues with portability. Along the course of time, we sent a skin to the Galveston Burn Center, the Boston Burn Center, Sacramento, and we even sent some for an adult in Canada, Edmonton, where Dr. Tredget had my former burn fellow in his burn unit, and said, hey, let's see if those guys can send us skin. And we would ship them, whatever it was, 2 square feet or whatever amount of skin it was, and they used it. So it was pretty self-explanatory in terms of its use. What's happened in the meantime is neither the university as the sponsor or Shriners wanted to own it, if you will. And so licenses and the like have been sold. There are technology companies that are trying to begin a multi-center trial. Essentially, they ran out of money because of the costs related to the biofacility that was growing the skin. And now the company is actually working with, I believe, an international interest. And they're hoping to launch a new trial that will not target adults as the first line of treatment, but children. Children with extensive burns and children with congenital hairy nevus syndrome. We're hoping that that trial could be approved for early next year. And we would pick burn centers where they're willing to do it the way I would teach them how to do it. It's like anything else. You can't just read it out of a book and say, oh, I can do that. There's a lot involved in how you prepare the wounds and the like. And to me, the most important part when you do a skin graft, I mean, a first-year resident or a third-year medical student, if you give them a piece of skin, say, staple that on, and say, no, that's the dermis that goes down. Beyond that, anybody can put the graft on. The hard part, in my opinion, is the dressing that keeps that graft from moving. So for me, I never left the dressing to anybody. I never left it to residents. Occasionally, a 20-year OR nurse, I'd say, yeah, can you dress that arm while I do this one? But for me, the dressing was the most important thing. And the wound excision. this was not the kind of thing where you could be wrong about a few cell layers not being viable. You only get one chance with these folks. And Joe Fish used to say, do it right the first time. It applies in so many aspects of surgery, but when you have a big burn, you can't afford for a graft to not take. You've wasted the donor's site, and now the patient's got to wait and wait and wait some more, and every day they're in the hospital without wound coverage, it's a day that they're closer to getting septic and dying. So I know that it is portable. I know it has worked in other centers. My hope is that before they bury me, as a lot of my buddies have said, we'd like to see it somewhere for mass production so other places can have this. And obviously it'll have other, I mean, I really think that maybe this is the thing that can cure epidermolysis bullosa, which is a nightmare for our pediatric dermatologists.
Well, we have something for you.
More?
As a thank you for
I thought a hotel and some nice meals were just fine.
It is a, I don't want to drop it, but it's a nice little plaque stating that you were here for this year for the visiting professorship.
Thank you so much.
We really appreciate you coming all this way in your retirement.
Oh, it's never a problem coming to San Diego. I've left 95-degree heat and probably 85% humidity, which is kind of like the Burn OR that I retired from. But thank you so much. You've all been so hospitable.
I'm going to run to the OR. Yes, take care. I will. You too.